Okay, ladies and gentlemen, thank you for joining at APASL School e-learning series. My name is JinMo from Korea, and the co-chair is Professor Lesmana from Indonesia, and also co-chair is Zaigham Abbas from Pakistan. Today's topic for liver biopsy. As you know, the liver biopsy is an important and essential diagnostic method for doctors who major in hepatology field. Although the frequency has been reduced recently due to improvement of serologic diagnosis and the development of radiology examination, such as CT, MRI, ultrasonogram, and fibroscan, and liver biopsy-induced side effects such as breathing complication during examination. So at this time, we invited three expert professors and learn about how to make a safe liver biopsy. We have a question and comment time after all of the session. So I'd like to introduce first speaker, Professor Amar Mukund. He's an interventional radiologist, professor of ILBS and New Delhi. Today's title is Indications, Contraindications, Checklist, the procedure, prediction, and preventive and management of complication of percutaneous liver biopsy. Professor Mukund, please, is already with the video lecture.
Okay. So, hello all. I'm Dr. Amar Mukund, and I'll be talking about percutaneous liver biopsy tips and tricks. And first of all, I would be highly thankful and grateful to APASL School for providing me this opportunity to talk about percutaneous liver biopsy. I'm a radiologist at Institute of Liver and Biliary Sciences, and here we go. So, let us start with the indications for liver biopsy. So we all know that there are three basic indications, which includes diagnosis, and diagnosis would be for parenchymal liver disease, abnormal liver tests of unknown etiology, fever of unknown origin, focal or diffuse abnormalities on imaging studies, and prognosis. If we talk about prognosis, then staging of known parenchymal liver disease. So if you are talking about prognosis, we are giving a medications, definitely that is one of the indications. And lastly, but not least, management. So development of treatment plans based on histologic analysis. And the most common example would be autoimmune hepatitis. If you talk about contraindications, then there are two absolute contraindications, which include severe coagulopathy and uncooperative patients. And there are relative contraindications. However, for all these contraindications, we have some way or the other for performing biopsies. It may not be percutaneous, but there are other transvenous biopsies as well as endoscopic and surgical biopsies. So relative contraindications include ascites, dilated biliary radicals or cholangitis, amyloidosis, morbid obesity, and hypervascular space-occupying lesions. Coming to types of liver biopsy, so these are transcutaneous, that may be percutaneous, that is what I'll be talking about. Then it will be transvenous, which will be covered later on in the next talk, and there can be surgical as well as endoscopic liver biopsy. The first and the foremost is pre-biopsy counseling and consent and the patient's education. So patient should be told about the liver disease, other available non-invasive and invasive indications. So the patient has all the rights to know about all such things. Then we need to explain the risk versus benefit ratio of the biopsy, as well as we need to obtain a written informed consent. So these are very important before getting a biopsy done. Then there comes the hematological consideration before percutaneous liver biopsy. And it should be remembered that it is a high bleeding risk procedure. And as per the latest Society of Interventional Radiology Guideline 2019, it is considered as a high bleeding risk procedure. And just to brief you, that Society of Interventional Radiology recognizes only two kinds of procedures, a low bleeding risk procedure and a high bleeding risk procedure. So liver biopsy comes as a high bleeding risk procedure. Further, there is no specific cutoff for PTINR or platelet count. above which chance of bleeding may be reliably predicted. So this is as per the ACLD 2006. There has been no further modification. Until date, we don't know what is the best cutoff below which you will never have a bleeding. So it may have bleeding even with normal coagulation. But for a guideline, we can have a INR of less than 1.5, PT of less than 15 seconds, APTT of less than 40 seconds, not greater than 3 to 5 seconds from the normal, and platelet counts of more than 50,000. This is the basic minimal requirement. Then we should know about the antithrombotics, and it should be stopped. Like there are certain guidelines, you can go through the guideline or your institutional protocols, and accordingly you need to stop antithrombotics before going in for the biopsy, and different time frames are available for different kind of drugs. Then the checklist, which is very important, and I'll be talking one by one about it in the coming slides. Like we need to have a valid indication, then coagulation parameters should be within limit, and antithrombotics if they are to be stopped. The patient should be admitted, either if the patient is inpatient or the patient should have a daycare admission. Mostly for a routine patient, it is a daycare admission where he gets an admission in the morning and goes in the evening. There has to be a consent for biopsy. I talked about it. Selection of biopsy device. This is very important, whether you are going to take a suction biopsy or a cutting needle biopsy, although most of the guidelines would recommend a cutting needle. Availability of ultrasound for real-time guidance. This is the most upcoming thing, and majority of the guidelines would suggest that it is better to use USG for real-time guidance. You may still do a blind biopsy, but USG is the better way of doing a biopsy. Then you need to prepare the patient. That is very important, so that you don't inoculate or cause pain to the patient. Performing biopsy and tissue sample retrieval. Again, the next step after performing, you need to see the tissue and look for adequate sample. So whether the length of the sample obtained is adequate for making the diagnosis. Although it will be confirmed by during histopathology, but the size, the length, you can always see. Then post-biopsy care, most important thing, because we know that it is a high bleeding risk procedure. Coming to role of imaging, so wherever possible, imaging guidance should be used to minimize the complications, and USG being a real-time modality may reduce the risk of complications. However, for a blind liver biopsy, a recent imaging within preceding 3 months in a patient with stable liver disease, this is very important. If we take a recent imaging, it should be within 3 months, but only in patients with stable liver disease should be reviewed. And image guidance is invariably required for focal liver lesions, altered anatomy, obese patients, and patients with clinically evident ascites. Then coming to imaging modality, ultrasound is the most commonly used, CT is rarely used, and this is how a patient is prepared. So you can see here the ultrasound machine is here by the side of the patient. The patient is lying supine on the bed. The hands are comfortably kept above the head, and the abdomen is prepared, and there is a nice big drape so that you don't contaminate any of the surface. The surface is cleaned with betadine. And if you are using ultrasound guidance, you can just wrap it with a sterile sheet or a plastic sheet, sterile sheet, and then you have a biopsy gun and then local anesthesia. This is how you inoculate the local anesthetic drug. Mostly it is lignocaine, and it is given over here. And when you put the lignocaine, you can see this is my needle coming up to the surface of the liver, up to the liver capsule. So because it is a image guided, we also see where my needle is going while giving a local anesthesia, and even the capsule should be nicely infiltrated over here. Then once it is done, we start with biopsy. So this is how a biopsy is being performed. And before performing biopsy, you always ask the patient to hold his breath. So patient is in breath holding position, and the needle is being advanced. We are looking that there are no vessels around. Then it is quickly taken. The biopsy is quickly taken and taken out. I'll run it again just to show you how it is done. We had first infiltrated lignocaine up to this surface, then biopsy has been, the needle is being advanced. There are no vessels over here, and it is my probe which is moving. The patient is in breath hold position, and this is how there is no vessel over here. Biopsy has been taken, and we come out. So this is how a biopsy is nicely performed. So just to recapitulate, what is the technique? Patient should be fasting for 4 to 6 hours. It is mostly performed under local anesthesia, that is lignocaine. Supine position with hands comfortably resting behind the head, which I have shown in the image. Hemodynamic monitoring should be in place. Breathing instructions should all be given. And the site which mostly should be taken is mid-axillary line at 6th to 7th intercostal space. But if you follow me, then I'll actually go slightly anterior to the mid-axillary line to avoid any pleural transgression, because the pleura is, a bit superior anteriorly and it comes very low in posterior part of the thorax. Then infiltration of skin puncture site till liver capsule, which I have shown. Biopsy is taken during breath holding in expiration, which is again I explained. After biopsy, local dressing is applied and patient is lied in right lateral decubitus to provide local site compression. So from the site where biopsy is taken, you ask the patient to lie down accordingly on the same side, and then the patient lies like that for at least 2 hours, and the patient should be observed for 6 to 8 hours. So this is the basic minimum, that 6 to 8 hours, and you may actually have other monitoring devices attached to the patient for initial 1 hour, and you may get a serial ultrasound done in case there is any pain or discomfort to the patient, which I'll be talking about. Then there is some modification in percutaneous biopsy, like we have percutaneous plugged liver biopsy. This is done in patients with slightly high risk for bleeding, like patients having small liver, cirrhotic liver, or with minimally impaired coagulation, like those which are not fitting into the normal coagulation parameters. It is slightly cheaper than the transjugular liver biopsy, as the major hardware and cath lab is not required, or even fluoroscopy is not required for performing this fluoroscopy. It can be done under ultrasound guidance. And after obtaining biopsy core, biopsy tract is plugged with gel foam slurry while removing the introducer needle. Glue or embolization coil can also be used instead of gel foam to close that percutaneous tract through which biopsy is obtained. And this is the simple way of preparing a gel foam slurry. You can just scrap the gel foam pad. So this is the gel foam pad. You can scrap it. You can take this scrapings into a syringe, and you can mix it with a saline using a 3-way, and you can make a thick paste or a gel foam slurry, and just 0.5 ml should be injected, not more than 0.5 ml of it, into the outer sheath through which biopsy gun is taken inside the liver, and that is good enough to actually plug the tract. Alternatively, you can use other sealant and collagen-based or thrombin or collagen-based sealants for this tract closure, or sometimes people may also like to use coil or glue for closure of the coil. So coming to size and type of biopsy needle. So preference is cutting needle over the suction needle. Still, some people may prefer using suction needle. Automatic cutting needle yields a longer core than a suction than a semi-automatic needle, and 16 gauge needle is recommended for diagnosis of diffuse parenchymal liver disease, whereas 18G needles is sufficient for focal liver lesion. And this is how a cutting biopsy needle works. If this is, suppose this is a liver, so this is how a cutting needle is, where there is a needle, there is a slot over here, and first of all, this needle gets inside the liver. Here is the slot in which the tissue is trapped, and thereafter the sheath, the outer sheath, quickly comes and cuts this piece of the liver into the slot. So this is how it happens, and as soon as you withdraw this needle, you will find this specimen lying within the slot. So it nicely works. So what is the adequate specimen? So if it should be 20 millimeter of length and should contain 11 portal tracts. So this is an adequate sample. And what is inadequate? Less than 10 mm length and less than 6 portal tracts. So this is inadequate. So a diagnosis may not be nicely made with inadequate sample, but we may have in between a compromised sample where the tissue is more than 10 millimeter length and 6 portal tracts, but not 11 portal tracts. A second pass should be considered if core is less than 20 millimeter long. And for diagnosis of other conditions, core should be 10 millimeter. So for any lesion, even a 10 millimeter sample should be sufficient. So coming to complications, there may be, there is a whole list of complications. However, the most common would be the pain and hemorrhage, but there may be arteriovenous fistulas, biperitonitis, pneumothorax. But if you take different precautions, then you are not going to perforate the viscus, you are not going to perforate the gallbladder, especially with imaging guidance. So the two more common thing which we are left with is pain and hemorrhage. So pain is the most common complications, while hemorrhage is the most dreaded complications. And hemorrhage is mostly due to injury to smaller arteries, which is not visualized even during USG guided biopsies. So signs of bleeding should be looked for, like persistent local site or right shoulder pain, not responding to oral pain medication, or if patient has hypotension and tachycardia, and if you do a ABG analysis, then probably you may find a drop in hemoglobin and hematocrit. So we should aim for an early detection of local site hematoma or hemoperitoneum by interval ultrasound screening. So how do we manage the complications? If the patient presents with pain, mostly it is reassurance. If pain still persists, then the patient may be given analgesics. And despite analgesics, if patient complains of pain, then ultrasound screening is indicated to look for any other complications. If there is any hematoma which is seen on ultrasound, a CT angio should be done. In a case of stable hematoma, observation and blood product transfusion should be adequate. However, if you find an active bleed, then transarterial embolization is required. And I'll show you one of the example. This is a post-biopsy CT angiography. You can see this is the liver margin. This red arrow shows you the liver margin, and this particular gray area contained within this yellow marking outline is the hematoma. So this is a fresh hematoma, and if you see carefully, this is an active contrast leak. This is an active contrast leak. Again, in the coronal reformatted image, you will see this active contrast leak. This is the liver surface, and this is the hematoma which is gradually growing in size. So this patient presented with pain. We picked it early with on ultrasound. We did an CT scan, and thereafter the patient was taken up for embolization. This is the arteriogram which has been done, and we went into the segment 4 artery. We placed an embolization coil, and this is how it is a post-embolization angiogram is seen. So patient was absolutely stable, didn't require even transfusion. So with this, I'll be ending my talk. And this is the take-home message for this particular talk, that liver biopsy is a simple day care procedure with a very low complications in a meticulously selected patient. So patient selection is very important. Most guidelines prefer USG guidance in all planned cases for percutaneous liver biopsy. Plugged liver biopsy may be an alternative to TGLP in patients with borderline coagulation management derangement. So we need to see that it is borderline coagulation derangement, and if there is any gross coagulation derangement, then transjugular liver biopsy should be the answer. And post biopsy monitoring is important for early detection of major complications and thus a timely interventions. Thank you so much for your kind attention. Thank you.
Thank you, Professor Mukund. Thank you. Nice presentation. Today we have 3 topics. So the second topics we introduce Professor Zaigham Abbas. Zaigham, please.
Yeah.
Good morning, good afternoon. First of all, I would like to thank you, the APASL, to inviting me to give this small lecture about how do I do it in hepatology and how do we do transjugular liver biopsy in our center in Barcelona. Well, these are the indications when we use usually the transjugular approach to get a liver sample. And it is, of course, for patients with a high risk of bleeding, with very severe clotting disorders, a platelet count below 50,000, and time of prothrombin below 50%, patients that they have a higher risk of bleeding because other associated conditions, as a matter of example, chronic kidney failure, or other patients that because of moderate or severe ascites, it's quite difficult to get a liver sample through percutaneous approach. I must say that usually the counts and the clotting disorders, the paradigm is being changed, and probably we can use in very strict conditions the percutaneous approach, even with lower platelet counts than the ones that I mentioned here, the thresholds that I am mentioning here. But this is not the reason, and I would say generally when the physician taking care of the patient thinks that the patient is a high risk of bleeding. In addition, in patients with obesity, morbid obesity, sometimes it's very difficult to get the percutaneous approach, or sometimes they have tried first to do a percutaneous biopsy, but they have failed. And probably more and more frequently, we found patients, or there are patients referred to our center that they want to analyze the presence or the absence of severe portal hypertension through an hepatic venous pressure measurement study, and then we can get a simultaneous hemodynamic study. This is what we call 1 in 2, because if they want us to measure the hepatic venous pressure gradient, it's quite easy during this same procedure to get a liver sample, and then this is one of the main indications that we are doing currently, transjugular liver biopsy in our center. What are the contraindications? I would say that the contraindications are very, very few if you are in a center that has a lot of experience in doing this technique. I must say that we are doing around 250 every year for the last 15 years. That means that we have done many, many transjugular liver biopsies in our centers. But here in this slide, I summarize some of the potential contraindications. Of course, the fact that we can puncture the biliary tract, we will see this later as a potential complications of the procedure, of what we can puncture and promote a bleeding inside a polycystic liver disease. Probably these are the two main contraindications. Also, if we think that there is a tumor, that we can spread the tumor into the vasculature, probably these are also potential contraindications to the procedure. I would say that the inability to be performed is when there is not an adequate vein access, the right jugular vein is thrombosed. That could happen in patients that have been submitted to many previous interventions, that they have been treated or required the jugular access during long time in hospitalizations. But in this situation, we can do the transjugular liver biopsy through the left jugular vein, or even in some places, I will say that we have not experience on using the femoral approach, but this can be done, and there are centers that are able to do the transjugular liver biopsy through the femoral approach, although I would say that this is anecdotic, and usually through the right or the left, I would say that it could be possible to perform the transjugular liver biopsy in almost 100% of the cases. This is the setting of the material that we currently use. Actually, this was the device that we use, the needle and the sheet and the aspiration sheeting. And with this is the technique that we use when we were performing aspiration. This is the procedure, the catheter with the needle inside the catheter, and we puncture the liver while we promote aspiration to get a sample from the liver, a sample liver through aspiration while puncturing the liver, crossing the wall of the hepatic vein. However, this has changed a lot, and since the last probably now 15 years, we are using the new device from Cook, the TrueCook needle. As you can see here, this is very similar to the percutaneous needle, that when you puncture the liver, it opens, and in this hole, the liver deposits in this area, and then after doing the shot of the needle, there is a cut and you get the sample inside and you retire it. This is the setting that it can be used. I would like to take into account this is the needle and this is the throughput system that goes inside the needle. As you can see here, you put it through this needle and the needle through the blue sheet. And these are the differences. As you can see here, when you do a transjugular liver biopsy of a liver with severe or with fibrosis, usually what do you get is this kind of fragmented pieces of the liver. Quite difficult sometimes to get a good appreciation of the structural alteration of the liver. And this, look at here, how much better is the sample that you usually get through a throughput transjugular liver biopsy. That is why in our center, we always use now, since the last 10 years, in 100% of our procedures, we use this throughput system instead of the aspiration system. However, the system that is available in the market to do the throughput, the one that I showed to you, has a problem, is that sometimes the livers that we are trying to get a sample are a small liver, that the hepatic vein has a sharp angle, as you can see here, that then is quite difficult to advance the needle into the liver because to cross this sharp angle is really, really difficult. And that's why we made a small modification of the system. And you will see here, this is the system that we use. This is from the old system, the black sheet with the needle used for aspiration. And this is from the new system, the throughput needle. As you can see here in this video, this needle is tremendously much more flexible, as you can see here, in a much more flexible than the original needle that comes with the throughput device that we used before. And then using this system, we are able to go through very angled hepatic veins to be able to enter the liver with the needle and then to perform the transjugular liver biopsy. And then this is the setting that we are using, as I said to you, the needle and the black sheet that we use it for the aspiration needle, but in addition, we use the throughput system. And then it is very important when we are going to do a transjugular liver biopsy to be sure in which hepatic vein we are located, because in the X-ray, it is very difficult to differentiate when we are inside the hepatic vein if we are in the right hepatic vein or in the middle hepatic vein. And as you can see now in this small video that I will show to you, the system or the technique changed a little bit, and this is very important to know it for doing a safe procedure. This is the video. You can see here the video. Okay, these are the black sheet. Imagine that is inside the hepatic vein, and then you advance the needle. And you need to look always very careful to the arrow of the needle. When the arrow is in this position, marking to the right, then that means that we are located in the right hepatic vein. And what we need to do is turn on and in counterclockwise direction the needle to do a puncture and cross the hepatic vein wall, to cross the hepatic vein wall. And this is the system to be sure that is because we are coming from the right hepatic vein. However, when we place the needle and we saw that the needle marks to the top of the patient, like in this position, as you can see here, that means that we are located not in the right hepatic vein, but in the medium hepatic vein. If in this position we decided to turn counterclockwise the needle and then to push, if we do it in that position, that's wrong, because we are in the possibility to cross the capsule of the vein. And that's very important. When we are in the right hepatic vein, we turn up the needle. When we are in the mean hepatic vein, we, as you can see now, when we are in this position, to cross the hepatic vein wall, we need to turn in the needle in the clockwise sense to the right to cross the hepatic vein wall. Now, once we are there in the position, now because of the position of the arrow, we are in the right hepatic vein, we enter the throughput system inside this needle. Once we are in the tip of the catheter, we turn counterclockwise, and then we cross with the throughput system and we do the shot, as you can see here. This is one of the examples that you can see here. We are in the hepatic vein. We don't know if we are in the mean or in the median or in the right. We will know that according with the direction of the arrow in our hands. As I said to you, if the arrow is directed to the right, that means that we are in the right. It is turning up, but that means that we are in the medium. And that makes to decide how we will do the movement of our needle to do the puncture. Once we have decided that, we do the movement, and now we do, as you can see here now, the needle is here, we open the throughput system and we do the shot. What are the complications, the main complications of the transjugular liver biopsy? Well, there are some that comes related to the vein access, and some of them are very frequent. The nick hematoma, a puncture of the carotid vein. Some are more rare and are related in most of the cases to the puncture of the carotid vein or the nerve. We can promote a Horner syndrome, pneumothorax, or an arteriovenous fistula. This is very rare. And I would say that since we introduce the ultrasound guidance of the puncture of the jugular vein, as you can see here, this is a real patient with the jugular vein, with the needle inside the jugular vein, and here, far from here, the carotid artery. Then by using that, it is clear that the possibility to do inadvertent punctures of the carotid artery is much, much rare, and the number of problems related to the vein access is markedly reduced. Another potential complications are related to the way from the jugular vein to the hepatic vein. We need to cross the atrium, and this can make arrhythmias, and mainly frequent supraventricular arrhythmia. And then in some cases, to cross from the atrium to the cava, inferior vena cava, and then to the hepatic vein may be difficult. And in these situations, it's much better to go with directly using a guide wire that goes directly to the inferior vena cava without many attempts to cross the atrium that may promote some atrium arrhythmias that may promote some damage to our patient. And also we need to be very careful because there are some very anecdotic cases. I have never seen this in our institution of lesions because of the needle of the jugular vein can promote damage here. Then you need to go with the needle once your catheter, with or without your guide, is already inside the hepatic vein. Other complications are indeed related to the fact that we are getting a sample of the liver. We can promote hepatic hematomas, subcapsular punctures, accident renal or colonic punctures, hemophilia, biliary fistula, hepatoportal fistula, arteriovenous fistula, and intraperitoneal hemorrhage as a consequence of the subcapsular or capsular puncture and perforation of the liver. Again, taking into consideration what I mentioned about what is the vein that you have catheterized, if the right or the median hepatic vein, to be very carefully controlling the introduction of the needle into the liver, and indeed having previous imaging study that discards a bile duct dilatation or a marked alteration in the liver morphology, we may need a liver biopsy in a patient with a severe atrophy of the right hepatic lobe. And then if we do not know that, and we do not take into consideration that issue, we may promote intraperitoneal hemorrhage or perforations of the subcapsular. I think that, again, this is a technique that requires expertise, but in our center, people come in to learn the technique after 1-2 months, especially if they are able to do HBPG measurements and to catheterize the hepatic vein. They get the expertise to do it without almost any problem, with a previous ultrasound, with a good study of the anatomy, and also with a good control of the hepatic vein that you are doing the puncture, and doing the jugular vein puncture with, as I mentioned to you, ultrasound control of the place that you are going to do. And I think that that's all for today. I would like to thank you, the people in our unit, that we will be happy to do more teach whenever you want to come to Barcelona. Thank you for your attention. I am ready to take questions from you and from the audience. Thank you a lot.
Yeah, Professor Pagán, thank you for your excellent presentation. We have a last speaker, and if you have a question and comment, please use a Q&A at baseline. The last speaker is introduced by Professor Zaigham Abbas. Professor Abbas, please.
Okay, our next speaker is Professor Anthony Dohan, and the topic he would be discussing is the managing complications during transjugular liver biopsy, tips and tricks. Professor John.
Thank you, Professor Abbas. Good morning. Hello to everybody. I'm Anthony Dohan. I'm working in Paris, and I will speak today about how to manage complications during transjugular liver biopsy, and I will try to provide you some tips and tricks. As you will see, transjugular liver biopsy complications are not so frequent, hopefully, and but you have to be aware at what can happening and what are the solutions that are available. So the first complication, the more frequent, is the cervical hematoma that may happen, especially if you don't use ultrasound guidance to puncture the jugular vein. It can happen because you puncture by accident an arterial vessel, like the carotid, for example, or if the jugular vein is behind the carotid, or if there is another artery in the region. And most of time, this simple superficial hematoma can be managed just by manual compression. However, sometimes it's not sufficient, and here you have a case of a patient who had a cervical hematoma, and you can see that the puncture was on the left side, and you see that the hematoma is behind the jugular vein. And one of the reasons why it may happen is that the technique to puncture the vein, there is one technique that is to transfix both walls of the vein, and in this case you can make an injury behind the vein. And in this special case, patient had a CT angiography just after the biopsy, and that shows this extravasation of contrast behind the vein. So in this case, there was an arterial injury not amendable to a simple manual compression. So what you have to do in this case is to get back the patient in angiosuit and to perform a selective embolization. And what we did there, and you can see that the extravasation here on in the thyroid region, and the selective angiography was performed through a radial access, and the branch was selectively embolized with coils. And as this is a rich anastomotic region, there is no risk of ischemic complication in this case. So when you have an arterial injury, non-compressible, you will have to do most of the time a selective embolization. The second complication that is quite often is when you have having trouble in the rhythm of patients, and like supraventricular arrhythmia. And it especially happens when your tip of your guide wire is inside the right ventricle, when you have difficulties to access the inferior vena cava. But usually when your sheath is inside the right atrium and is from the superior vena cava to the inferior vena cava, it will disappear. So what you have to do when you have an arrhythmia is to get out the right ventricle as fast as possible. If it's just paroxystic and it stops when you get out the ventricle, then you can continue the intervention and just try to go as fast as possible to avoid the arrhythmia to stay, and otherwise you will have to stop the intervention if there is a complete supraventricular arrhythmia that doesn't stop, and you will have to call the rhythmologist. That usually we do. We don't not manage ourselves this kind of complications. The most classical complication, which is quite rare, but honestly it happens, is to have a perforation of liver capsule. As you know, in the contrary to the percutaneous access, when you have the transjugular access, you do not see the parenchyma of the liver, except if you use ultrasound, a double guidance with ultrasound and X-ray, but it's not the case in most of cases. So if your needle is very far in the liver, but you can see like here, when you perform the biopsy, you may biopsy the liver capsule. And when you do the angiogram after the biopsy, you will see extravasation of contrast. And here you can see on the CT that the contrast is in the subcapsular area. So if it remains in the subcapsular area, usually it may be sufficient to compress the venous system and to make the hemostasis. But patients that are amenable to transjugular liver biopsy, it's usually because they have hemostatic troubles. So if you are in the vein with a sheath and you have extravasation of contrast, what we do usually is to use temporary embolization material, such as gelatin sponge, that we inject distally to slow the flow of blood and to help the spontaneous coagulation. And usually that's sufficient. We don't use definitive embolization materials such as coils or glue, because it's just it will heal by itself in some minutes or hours, and the gelatin sponge may be very helpful to simplify and to make it more efficient. All the case, and you can see here the perforation was more deep, and there is an extravasation of contrast outside the liver capsule in the peritoneum. So this kind of complication may really happen. And embolization is not compulsory in every case, but we, when it happens, usually we do it. Another complication that you can have is an arterial injury. When you do the biopsy, you don't see if there is an artery or a portal vein or a biliary branch, and they can be cut by the biopsy catheter, the biopsy needle. And in this case, just after the biopsy, you see an extravasation of contrast. And on the CT angiography performed just after, you see an arterial extravasation of contrast in the territory of the biopsy, which confirm that there is a hole in the artery. And this kind of arterial injury may be severe, and usually it doesn't heal by itself. So when you have an arterial injury, you have to go back to angiosuit to perform liver angiography, and if possible, a superselective embolization of the territory that will not cause ischemic complication if the patient has normal portal vein system and no occlusion. But the arterial flow may be important, and without treatment, the patients can have a very, very large hematoma. Another complication that you can see after percutaneous or transjugular liver biopsy is an arterial injury that will heal as an arteriovenous fistula. As you puncture through the vein and you touch the artery, you can have an arteriovenous fistula that will remain. Sometimes the diagnostic is done without any symptoms, and you don't see it on the spot, because when you are in the vein, there is the pressure in the artery is higher, so you won't be able to opacify the arterial system during the biopsy. So you may see this just in a CT or an ultrasound performed in the follow-up of the patient, and this may be non-symptomatic most of the time. But if the patient has a severe arteriovenous shunt, and that may be symptomatic, and in this case, it's also the treatment is also to perform a super selective embolization with we use coil to make a definitive embolization of the fistula, of the of the feeder of the fistula, which is here, and usually it's very efficient. You can also have a portal vein injury. If you opacify after the biopsy, you can opacify the portal system. It's a bit like if you tried to do a TIPS. But the portal system has a low pressure, lowest than the arterial system, and usually this will heal simply by itself. So in this case, I do not recommend to perform any embolization. You risk to send your gelatin sponge or your coils in the portal system, and there is no need to do that. And if you don't stent, you don't dilate the tracts you made between the vein and the portal system, it will close by itself, and you won't have any complication of that. Another possibility, especially if your patient has dilated biliary tree with dilatation, and that's why it's a relative contraindication, you may puncture the biliary, your biopsy, and the angiogram you may opacify the biliary tree, like is here in this case. this may be problematic, especially if the biliary fluid is infected. So if you have a patient with ongoing sepsis, the best thing to do is to use antibiotics to try to control the bacteremia that may occur after this biliary venous shunt. But usually when you remove your sheath, the tract will close by itself. It won't there is no fistula that is going to remain, and just antibiotics in case of suspicion of bacteremia should be sufficient to avoid a septicemia. Finally, this is not really a complication. This is a non-target biopsy, which is it's a complication, and it occurs sometimes in young fellows or for everybody. It can happen to everybody. Here in this case, you can see that the ribs are here, so probably the needle is not is too low for liver biopsy, and you can see the biopsy here. And when you opacify after the biopsy, you see the kidney cavities that are opacifying. So clearly, that's something that happen, or at least once in a career, to everybody. But hopefully, there is no complication for the patient, except that if you don't realize on the spot that you are in the kidney, you have to re-perform the liver biopsy. So, but it's something that may happen, and that may happen also when you perform the liver biopsy percutaneously without ultrasound guidance. That's also why it's not recommended at all. As a conclusion, I will say that complications are not frequent. So when you have one, try to make a video because it may be useful if you have a talk to do about. Anyway, if you have an arterial injury, you will probably have to do a superselective arterial embolization because this kind of injury will hardly heal by itself. If you have a capsule perforation, which may happen sometimes, you can do a venous embolization, but I recommend to use temporarily resorbable materials such as gelatin rather than definitive embolization materials. And the other complication, just you have to keep calm, and it will go good for the patients. Thank you for your attention.
Thanks, Professor Dohan. So now, for your nice informative presentation. Now it's time for question and comments for liver biopsy. I will announce a previous question. So first question is fast or postprandial state better for liver biopsy with regard to GB gallbladder emptying. So Professor Mukund's answer is there is no standard guideline regarding the fasting status. If guided biopsy is being done, it's preferable to have a 4-hour fasting, that there is no major chance of liver injury, gallbladder injury. So postprandial state leads to increased mesenteric flow and has a potential to have a bleed. So the fasting state is better. And aspiration is another issue related to the postprandial state. And another question is, please comment the use of tag and load used instead of standard bleeding parameters prior to liver biopsy? So Professor Mukund answer is recently British Society Royal College guidelines have advocated for using taglutam prior to liver biopsy. However, other guidelines have not mentioned about it, but if you ask my preference, then it should be done to know about coagulation. So another question is a cirrhotic liver, one may not get a 2cm liver tissue. Comment please. Professor Mukund, answer is in cirrhotic liver, you do get 2cm tissue while doing percutaneous liver biopsy, but the problem is fragmentation of tissue. 2cm length is required as we need 11 portal tracks for making a precise diagnosis. However, if by any chance you are not getting adequate sample length, then may kindly use coaxial system through which you can obtain 2 to 3 as many samples you needed and may plug the track while withdrawing the coaxial needle. And another question is in transjugular liver biopsy, should one match the needle as HVG and then push the needle to take a biopsy? Professor Pagan's answer is no. Is there another question? I have another question to Professor Mukund. You mentioned about the Percutaneous liver biopsy at the daycare center. And do you have any guidance or patient classification for inpatient or outpatient? Outpatient means a daycare center, inpatient in the after admission. Is there any patient classification?
No, mostly inpatients are those who are sicker patients. So you would invariably mean that most of the patients are having some of the symptoms which require admission. If it is that admission is pertaining to chronic liver disease and decompensation, then probably he may not be a fit candidate to undergo a percutaneous liver biopsy. However, in case it is a borderline derangement, coagulation derangement, then you may still go for percutaneous liver biopsy because it is quick. The sample quality is better and the length of the sample obtained is much better because in transjugular liver biopsy, the best needle available is 19G needle, in which what the sample what you get is a bit crushed one. So if you really want to get a good sample, then percutaneous biopsy would give you a better sample, provided that you can plug that particular track. And now plugging the track, how do you plug the track? Then you have an outer needle, that is the sheath. You first insert it in the liver and then take a sample. However, percutaneous liver biopsy is a preferred approach for outpatient basis where the patient is initially diagnosed with a or suspicion of a parenchymal liver disease and you want to confirm your diagnosis or know the level of fibrosis despite having non-invasive measures. You want to know something extra apart from what you already have from non-invasive tests. Then it is done as a daycare procedure where you admit the patient. Normally at our center, a patient is 4 hours fasting. We take a biopsy. We observe the patient for 4 to 6 hours and we invariably do a ultrasound screening before discharging the patient to look for any inadvertent bleed, which patient is not complaining pain or something like that. So we always do a screening ultrasound before discharging the patient, even if it is a daycare procedure, to prevent any major complication.
Thank you. So any other question? And Professor Mukund, nowadays the liver biopsy is performed in patients with NAFLD and NASH and autoimmune hepatitis. Usually. The major complication is bleeding. So
yeah.
If the patient, you choose percutaneous liver biopsy or transjugular liver biopsy. What is preferred?
Yeah, we do know that most of the patients who have a normal coagulation, the chances of bleed is pretty less. And with the kind of devices what we have and the kind of experience what we have in our institute and as per all the available literature and the guidelines, we know that the bleeding complication is pretty less. If it is dreaded. So what we know that bleeding cannot be prevented, but you can catch it early. So our aim is to catch it early if we are having a bleed. That's why ultrasound monitoring. So first you do a guided biopsy that will prevent any advertent, injury to adjacent viscera or the vessel. So first you prevent any bleeding chances because of guidance. That is a real-time guidance using ultrasound. In case inadvertently there is any bleed, if you do a serial ultrasound in a patient who has any suspicion, like first he will complain. If by reassurance it is not going, you give analgesics. Still, if he is having pain, go for an ultrasound. And sometimes if there is minimal fluid, just monitor it. If it is increasing, get a CT angio done. As soon as if you find that there is a growing hematoma with a contrast extravasation, an active leak, we immediately take the patient for embolization. We had 2 embolization in last 10 years, only just 2 embolizations, but we caught it very early and none of them required even a transfusion of blood because the drop in hematocrit or hemoglobin was just 1 gram. So you have to be very quick and you have to be in a liver unit. You have to see your patients very carefully and monitoring should be very stringent.
Thank you.
May I some questions? Dr.
Yeah, sure, please.
Okay. My first question is to Professor Anthony Dohan. Anthony, do you regularly use some antibiotics before performing transjugular liver biopsy? As one of the complications, especially in cirrhotic patients, maybe bacteremias and infections as a result of. So what is your recommendation using antibiotics before transjugular biopsy?
No, thank you for your question, Professor Abbas. In fact, we don't, for most patients, we don't use antibiotics specifically for the biopsy itself. Patients are sometimes treated by antibiotics because they come for a complication of ascites or of their liver function, but it's not the biopsy by itself as not a septic risk sufficient to suggest the use of antibiotic prophylaxis. Percutaneous or transjugular, both it's the same, but just in case of you have a complication and you may have bacteremia, because especially for when the patient has a sepsis pre-existing, for sure it's interesting to add antibiotics, but it's not routinely at all. No.
Thank you. Professor Juan Carlos, do you routinely measure hepatic venous pressure gradient when you are performing transjugular liver biopsy?
Yes, we do actually. We think that it offers usually new data that can help you in recognizing the disease. Probably it is not completely necessary, but in some cases that you have problems of the differential diagnosis, it may help. We use it as a routine, although I must say that probably there are some patients that the indication of the transjugular liver biopsy is just to discard autoimmune hepatitis or just to recognize the cause of a fulminant hepatic failure that probably is not needed, although sometimes you get additional information that can be of help, and usually it prolongs, in expert hands, it prolongs the technique probably just 10 minutes.
So have you ever tried in suspected but Chiari syndrome or some veno-occlusive disease transjugular liver biopsy, or this is a contraindicated if there is some blockage?
No, and absolutely not, because in Buchiari patients, usually even in the causes that we saw here in Europe and the United States are a little bit different from Asia, and in most of the cases, almost all the hepatic venous thrombose it's many times easy to go through this partially thrombosed or hepatic vein and then go into the liver. Although usually in Buch Chiari patients, we only perform biopsy when we have really doubts about the diagnosis, especially for a small hepatic vein Buch Chiari syndrome that there are no imaging data of a thrombosed vein. But usually, I mean, for us, it's not a contraindication at all. We can do it. Although I must say that regularly, we don't need a liver biopsy for the diagnosis of a patient with Buch Chiari. It's very rare.
Dr. Amar, may I ask you a question? Like many times we come across problem of stopping antiplatelets or oral anticoagulants, and sometimes these patients may be on warfarin. So when to stop these blood thinning agents or antiplatelet agents? How many days before, and when can we restart these agents after the liver biopsy? Amar?
Yes, sir. Thank you so much, sir, for your question. It's a very pertinent question. And we have a definite guidelines for all these drugs. Like for aspirin, we need to stop it before 5 to 7 days. But nowadays, aspirin is still, many times we prefer to give aspirin if a patient is on dual antiplatelets because of coronary artery disease and recently diagnosed and have a coronary stenting. So none of the cardiologists will ever like to stop both the antiplatelets. So in such a condition, you better stop clopidogrel and you continue with the aspirin. So with aspirin, you can always go ahead and do a biopsy. And normally for clopidogrel, it is 7 to 10 days when we stop clopidogrel, and then we start 48 hours after the procedure, any antiplatelet. We start 48 hours after the platelet. If it is unfractionated heparin, it is just, we can stop 24 hours before the procedure, and we can start it after 12 hours of the procedure. And as far as warfarin is concerned, we should stop it 5 days before the procedure, and we can start it 24 hours after the procedure. However, as per different guidelines, slightly mild changes are there. If you see the APASL guidelines, EASL guideline, or ASLD guidelines, or Royal College guidelines, so it is just 1 or 2 days. So it is all from 5 to 10 days what is needed. But with newer and oral anticoagulant, it is normally 24 to 48 hours, which you need to stop the agent, and thereafter you can start it after 24 hours of the procedure.
So should we rely on INR in cirrhotic patients? Because many times we say that INR is not a reliable indicator, because in cirrhosis there is a delicate balance of procoagulants and anticoagulants, and INR may not be a true reflection of the status of the patient.
Yes, sir.
So you still follow INR of 1.5, or you become more relaxed if the INR is 1.8 and 2, and you can still perform the liver biopsy?
So this is a very nice question, and in fact, one of the audience attendees has also asked this similar question. So if you ask me personally, yes, we should move to TEG and ROTEM. But the problem with TEG and ROTEM is it is not readily available, and the cost factor associated with it. So these are the two factors. Thirdly, still in the guidelines, if you see the guidelines, neither ASLD nor EASL guidelines or Bovino guidelines have still mentioned ROTEM and TEG. So for the sake of talking about guidelines, we don't have the guidelines except for the British Society and the Royal College guidelines, which have started talking about TEG and ROTEM. But if you ask my personal preference, wherever I feel that this patient may have some coagulation defect, yes, I insist to have at least any of these newer coagulation parameters test like ROTEM, TEG, or Sonoclot. Either of them, if you have any of them and you can correct it properly, then better to have all those tests done to avoid any mishappening. So that is very true, a very valid question, and I think in coming days we'll have guidelines on these things. Probably the cost issues are addressed and it is readily available across the centers. But till the time it is not available across the centers, probably we'll have to follow the previous guidelines like INR of 1.5 and platelets of 50,000.
So thromboelastography is the answer.
Yeah, that's the answer.
Yeah. Thank
So, any other question? No more question? Okay. I'd close today's session for liver biopsy. Many thanks to all of our audience and many thanks for your nice and informative presentation. Thank you, professors.
Thank you. Bye-bye.
Bye.
Thank you so much.
Bye.
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 Thank you.
Thank you. Bye-bye.
Bye.